came to us with the complaints of diminution of the vision in the left eye of about 1 month's duration. He was diagnosed elsewhere to have CMV retinitis of the left eye. His CD4 counts were 44. He had just been started on heart therapy and also on antituberculous therapy. On examination, his best corrected visual acuity in the right eye was 6/6. He was nil light perception in the left eye. The right eye was normal. The left eye had a bullous retinal detachment and vitritis. Further details could not be made out very clearly because of the dense vitritis. A B scan was done. B scan showed a closed funnel retinal detachment with subretinal echoes. This picture did not fit into any of the normal things that we see in HIV positive individuals. It looked more like a masquerade. So we suggested that we should go ahead with a retinal biopsy. The patient understood, because the nil light perception is a thing which you don't see with CMV retinitis unless the optic disc is completely burnt out. And so we suggested a retinal biopsy. The patient did undergo a retinal biopsy. The retinal biopsy showed, on histopathology you can see that there were his malignant lymphoids. There's malignant lymphoid cells, and immunohistochemistry with a pan B cell marker showed that it was positive for that, so it was a B cell lymphoma. It was diagnosed as a non-Hodgkin's B cell lymphoma. It was purely intraocular, there were no CNS lesions. He was investigated for that. Patient was advised radiotherapy and chemotherapy. He underwent 6 cycles of chemotherapy, and 12 months later he was doing pretty well. He came back to us 3 years later. He had a white mass lesion on the eye now. He had a white mass lesion which looks like a squamous cell carcinoma. His CD4 at this time was 380. It looked clinically like a squamous cell carcinoma. We suggested enucleation along with a white conjunctival resection. The patient underwent the same, and we can see here that there is a lot of conjunctival dysplasia, and there's also early formation of squamous nest, suggestive of a squamous cell carcinoma. There's also areas of necrosis, intraocular necrosis, which could be post-radiotherapy, and there's also some amount of osseous bone formation in the coats of the eye, which is quite characteristic of Thesical eyes. This eye was Thesical by now. The second case is a 42-year-old, again HIV positive male. He came to us with history of diplopia and drooping of the left upper eyelid of 2 weeks duration. He also complained of a mild deviation of the angle of the mouth to the left side and pain in the left eye. He had had a normal ocular examination about a month previously. He was on heart therapy. His CD4 was 178 presently. On examination, he had a complete left third cranial nerve palsy and a right partial lower motor neuron palsy. CT scan did show that there was a large mass lesion involving the right maxillary antrum. It had extended temporally, eroding the bone, and it had also extended posteriorly intracranially. He also had multiple small firm cervical lymph nodes which are palpable. His respiratory, otorhinolaryngological, cardiac and abdominal examinations were normal. His chest X-ray, however, showed right-sided pleural effusion. However, a pleural tap did not indicate any malignancy or tuberculosis. So a nasoendoscopic biopsy of the lesion was done, and HNE showed a poorly differentiated malignant neoplasm. Immunohistochemistry for leukocyte common antigen was positive for 50% of the cells. LCA is done for NK cells, natural killer cells, and CD3 positivity for 30% of the malignant cells. This is again indicates a T cell origin because CD3 is T cell marker. Cytokeratin and CD20 were negative. Cytokeratin is for squamous cell origin, CD20 is for B cell origin. Both of them were negative. However, Epstein-Barr virus was strongly positive. This is the malignant dysplastic malignancy that we see. LCA common for about 50% of the cells, CD3 positive for 30% of the cells, and Epstein-Barr strongly positive. So here we had an NK T cell lymphoma of the nasal type, which is quite a rare tumor. He underwent a bone marrow aspiration, and it showed atypical lymphoid cells which were infiltrating the marrow. He was diagnosed to have stage 4 non-Hodgkin's lymphoma. He was advised low-dose chemotherapy with the following drugs. He developed complete blindness for a few weeks, and he expired before the second cycle of chemotherapy. So here we had two cases of an unusual presentation of malignancies in HIV. Of course, the role of viruses in malignancies in the heart era in HIV individuals is much debated already. In case 1, we had two successive ocular malignancies in the same person, in the same eye, both with a favorable outcome. He had an intraocular lymphoma. Lymphomas in HIV setting are known to be associated with Epstein-Barr virus infections, because when the immunity comes down, EBV does take over and there is an abnormal proliferation. So, though in the first case we did not hit the nail on the head and identify EBV, but literature does say that EBV is associated with that. The CD4 counts were very low when he developed the lymphoma. Next, he subsequently developed a squamous cell carcinoma. Squamous cell carcinomas in the setting of HIV, again, you see more commonly because possibly of the human papilloma virus. But in this case, it was also compounded by the fact that he had undergone radiotherapy, and also because of the climate in which we are, tropical climate, it increases the incidence of squamous cell carcinomas. In case 2, we saw a very rare type of a lymphoma, and here the role of Epstein-Barr virus was nailed by immunohistochemistry, and because of the aggressive nature of this tumor, the patient had a very poor prognosis. The second series of cases is again which develops in immunocompromised individuals. The first case of which is a 30-year-old male gentleman. He came to us with slowly deteriorating vision, which he complained as basically tunnel vision in both eyes, which had come down to counting finger 1 meter since the last 1 year. He was a known case of HIV for the last 6 years. He was not on any treatment. His CD4 counts were 120. His visual acuity was counting finger 1 meter in both eyes. The pupils were mid-dilated and sluggishly reacting in both eyes. His fundus showed something like this, which is like optic atrophy in both the eyes. His visual fields, which were done about 2 or 3 months ago elsewhere, showed a gross concentric constriction of the visual fields. He could not do the fields now at this stage. His visual evoked potential showed a delay in latency as well as a small amplitude in the P wave. This was also done previously. Vision after heart. So at this point in time, basically we investigated him thoroughly and we didn't find any reason why he should have optic atrophy. There was nothing we could offer to him. But since his CD4 was about 120, he was put on heart therapy. He started heart, and about a few months later he started improving, and at 7 months he had vision of 618 and 612 in the right and left eye. And the patient was pretty sure that his visual improvement started with heart therapy. Case 2 was a girl, 13-year-old girl, who came with actually no complaints. She came just for routine examination. Her disc in the right eye looked something like this. In the left eye she had optic atrophy. Vision was 6/9 in the right eye. Left eye counting finger half meter. She had not noticed the drop in her left eye vision. Her CD4 counts was 287 at this point in time. Advisor fields for her. Left eye she could not do the fields. Right eye fields showed grossly concentric visual fields. At this point in time, we again investigated it thoroughly, couldn't identify a cause for the optic atrophy. But by now we were pleasantly surprised by the outcome of the previous case. So I suggested to the treating physician, why not start her on heart? The physician was not very clear. She said, no, there's no other indication to start heart therapy in her yet. But on insistence, they did start her on heart therapy. And sure enough, after 4 months after starting therapy, her visual fields did improve. Her, the field of vision had improved. This was about 4 months later. And about 10 months later, the fields further improved and her vision was 6/6 in the right eye. The left eye, however, did not improve any further. We did a retinal nerve fiber analysis right through on her, and all along the retinal nerve fiber analysis was normal in both eyes. Even in the optic atrophy eye, there was no reduction in nerve fiber layer thickness. All these tests were actually done on both these patients to rule out possible infective etiologies. Serology was done for syphilis and toxoplasmosis. A CHEK6A and 1-2 was done to rule out tuberculosis. A CSF tap to rule out tuberculosis, tubercular meningitis, cryptococcosis, syphilis, and herpes simplex varicella and cytomegalovirus were ruled out. A CT scan was done to rule out intracranial space-occupying lesion. And a diagnosis of primary HIV optic neuropathy, which is basically a diagnosis of exclusion, was done. To discuss these two cases, primary optic neuropathy in a HIV positive patient is probably due to direct invasion of the HIV virus. We understand that the HIV virus or we used to understand that the HIV virus does not cause any ocular lesion apart from the corneal spots that we see. Most of them are because of opportunistic infections, but this possibly is one condition where the HIV virus directly has a role. There is some indirect evidence in CNS to show that this could be happening, and if we consider the optic nerve as an extension of CNS, we can extrapolate the same reasons here. And this was substantiated by the fact that there was improvement in vision and visual fields after starting heart therapy alone. There was no other therapy, no steroid, nothing else which was started. So this was one thing. But we did see that there was a very non-uniform improvement in vision after heart therapy. So then we need to say that probably the optic nerve passes, damage happens through two phases. One, there is an acute phase where there's a loss of nerve function, but there's no complete destruction of the nerves. This is where there is a marked improvement in vision after starting heart therapy. Then there's a chronic phase, which as we saw in the girl's case in the left eye, where there is irreversible loss of nerve function, that is, there's no improvement even after starting heart therapy. The visual fields were not described in primary HIV optic neuropathy before, but we saw that the constriction of visual fields is the most common visual field defect. Field changes may be noted in an otherwise asymptomatic eye, as we saw in one of our patients who were not even aware that she had such a gross change in fields. So routine visual field testing is in place. The retinal nerve fiber layer thickness was normal in the child that we saw. I've just shown two representative cases. Actually, we have a series of 8 cases which we have presented in the IJO. But in all of them, we saw that the retinal nerve fiber layer thickness was normal. It was not reduced. This could possibly be because this could be an infiltrative optic neuropathy. That means there could be infiltration of the nerves with either viral particles or inflammatory cells. That could be the reason why the thickness is not reduced. So to conclude, one is there needs to be an awareness of a condition called primary HIV optic neuropathy among the general ophthalmologists, because this has a good prognosis if it is detected early and treated early. Primary HIV optic neuropathy is probably an indication to start heart therapy, because there are very clear guidelines as to when you start heart therapy, but this possibly is one other indication which we need to think of. Constriction of visual fields was the most common visual field abnormality which we saw. However, further histopathological and clinical studies are required to study the pathogenesis of this condition.